بسم الله الرحمن الرحيم، صلى الله وسلم على رسول الله الكريم. اللهم اشرح لي صدري ويسر لي امري واحلل عقدة من لساني يفقهوا به قولي. اوكي، الدكتور فيصل البكوش صحيح؟
ايه من ايه؟
انت قاعد للنهايه؟
والله ان شاء الله، غير صبرني على ولدي بس.
خلاص، حتى انت حنحطك شو اسمها الكو هوست باش تبدا انت والدكتوره مروه فولو ان شاء الله. Okay, so thank you for everyone. I know it's very hard with Ramadan. Like, inshallah, we will make it as smooth as possible. Make sure that we answer all the questions. Okay, I have no financial disclosure. Okay, so the objective for this topic to review the basic and principle. زي ما عودتكم, we're going to talk about the physiology before we jump to the pathology. We're going to understand the rules of the non-invasive ventilation and high frequency, or the high flow nasal sorry, in the management of the RDS and bronchopulmonary dysplasia. هي نفسها chronic lung disease. And we're going to see the evidence, if there's any evidence, which one is ones. So, نعرفش قديش واحد, how many one of you guys attend my previous lecture about ventilation, لكن it's very good that we're going to go overview as a reminder. في نفس الوقت you have a solid physics and physiological background. So we're going to talk about the respiratory ventilation, we're going to talk about lung compliance, and we're going to talk about oxygenation ventilation and risk of the oxygenation. It's a very famous picture. I'm going to focus on the tidal volume. So the tidal volume, the amount of the in and out, the amount of in, out breath per cycle. When I ask you to do deep exhalation, that's called expiratory reserve volume. Like when I ask you to take the air out, that's called the deep or the expiratory reserve volume. And there is place that does not precipitate, that's called residual volume. Why I have to mention this one? Because you have something called functional residual capacity, which the expiratory reserve volume plus the residual volume. We will talk about it later on about how important. Okay, we discussed about respiratory ventilation. We have two different terminology. We have minute ventilation versus alveolar ventilation. If you have baby intubated or non-intubated, usually we call it minute ventilation, which is the amount of in and out per minute. Just example to make it connected to the physiology. If you have a baby who is not intubated, for example, or he's on non-invasive, and his respiratory rate is 80 beats per minute, and he's hypoxia or hypoxemic, sorry. Saturation low in the low 90s or the 80s, upper 80s to low 90s. فأنت إذا كان البيبي على non-invasive or he's on the invasive, in order to improve the minute ventilation, one of the best strategy what we do, we go up on the tidal volume. You give him either respiratory support, or if he's already on the respiratory support, you go up on your tidal volume. Once you go up in the tidal volume, you achieve minute ventilation, the patient respiratory rate is going to slow down. Make sense or no? So if you start with baby on intubated or NIV, or let's say intubated, he's on the 5 ml per kg, or he's on the bib if you are using pressure support of 25, or 20, sorry, 20. Your baby breath 80, normal. We know then the baby is usually 40 to 60, that's normal. Respiratory rate, beats per minute. And let me change the people, they ask me about changing the, okay, that's normal. Okay, so if the baby's breath 80 per minute, changes, okay. You know that baby very tachypneic, okay? So if your baby is very tachypneic and he's on the bib of, on the pressure supports, either non-invasive or invasive, doesn't matter, he's on the bib of 20. In this case, or bib of 5, the higher you give the tidal volume, your baby's respiratory is going to slow down because you achieve the goal of the minute ventilation. In other side, on the alveolar, if your baby intubated, and that's only if baby intubated. If baby intubated, you need to look at the dead space. What does it mean? So you have, if your baby already intubated, okay, or there is meconium or any other cause. In addition to the tidal volume and respiratory, there is another factor. It's a very important factor called dead space, okay? So what's the dead space? Dead space, we have two parts. I'm talking about physiological dead space. We have anatomical and we have the alveolar dead space. What's the factors that increase your anatomical dead space? If you have endotracheal tube, so the size of the endotracheal tube, the bigger, it's gonna have larger dead space, correct? Length of your tube, the longer you're gonna have the longer dead space you're gonna have. So if you have baby intubated, if you're using the old vents, sometimes what we do, we cut the tube, the endotracheal tube, to make it short, so we can limit the amount of dead space. Because as we said here in the previous, there is tidal volume minus dead space. So if your dead space is high, it's gonna affect on your tidal volume, and that's end up affecting your alveolar ventilation. So you need to be careful. Flow sensor. So as we know, that's the endotracheal tube. You intubate the baby, and that's the baby mouth. You always have a sensor here. There is always, in tiny baby less than 800, we usually add 0.8 centimeter or ml of on the tidal volume, and that's considered the dead space on the sensor. The sensor itself, it's mentioned, if you read the sensors, they mention that has 0.8 ml. So if babies, tiny baby less than 800 grams, usually we add the dead space because we need to overlap the, or we need to increase your tidal volume by 0.8 because you consider شنو اللي هو the flow sensor, dead space. And then suction. Suction, there's two. We don't. That's why I brought the next picture. This baby intubated, not intubated, he's a trach, but let's assume the baby intubated. We have a closed loop suction. Okay, so here the suction also it's considered because here that's the connector and that's the connection to the suction. So it's closed loop suction, and that's adding شنو اللي هو a dead space. فحتى هذه you need to consider. If the alveolar dead space, the alveolar, the factor affecting the alveolar dead space اللي هي hyperventilation. Let's assume that you have the baby who's already hyperexpanded, very hyperexpanded. Then it's going to be a lot of dead space adding in your affecting on your minute ventilation. If you have baby who is meconium, if you have baby who is meconium, sometimes what happens, let's clear this one, the screen, and I can explain. If you have baby meconium, let's assume that this is the airway, right and left main bronchus. If you have very big, medium-sized meconium plug here, what's gonna work? You're gonna do as a one-way valve. So that means during inspiration, your airway is dilated, so the air come in. And during the exhalation, what happened to the airway is gonna be bronchoconstriction, correct? And what happened here is gonna be air trapping. And that's air trapping can affect your VQ mismatch or can affect your ventilation, okay? The next factor is decreased pulmonary blood flow. Decreased pulmonary blood flow also affecting your VQ mismatch, and that can affect your alveolar, the space you increase, because what happens, what does it mean here? So if you have the alveoli, and that's the blood flow, if the blood flow is obstructed or decreased, what's gonna happen? It's the air stay here, does not ventilate. So the air is going to stay here. The number of air does not participate in gas exchange. It's going to increase, and that's going to increase your dead space. So again, very brief. You don't know, just you need to know basic. I don't want you guys to remember all these. So physiological dead space, we have anatomical and alveolar. If you don't remember them, it's fine. But what I need you to remember that the tube size, especially the length, that's something you can, size you cannot control it, correct? So the length you can control it. Sensor, you can control it. So those two values, we usually control it. So the new ventilation, usually it adjusted is auto-calculated, but the old ventilations, usually you need to cut your tube and make it shorter. Sensors, as I said, in tiny baby, you need to consider. Bigger baby, we don't consider. Other factors that affecting that you need to manage your ventilation to reduce the dead space, it's hyperventilation, if you have meconium, or if your blood flow is decreased. Again, we have anatomical dead space, alveolar dead space, obstruction, a lot of air does not participate in gas exchange. Lung compliance. So yes, last week we spoke about compliance, اللي هي how ease the lung stretch, correct? How ease. وشرحنا إن we explained the three type of socks. If you have the normal شخشير or socks or ملابس جديدة, it's easy إنك أنت تلبسها أو it's very easy stretch on your body. هذه that means is good compliance. We give another example. If you take the new dress and you put in laundry, what happened? Your dress usually becomes shorter, especially if it's not good quality. هذه معناتها شنو? It's your compliance is reduced. The same time, if you have very old شخشير or very old dress, usually what happens is become easily انك انت تلبسه وبيكم شنو loose. فهذا معناتها الكومبلاينس نتاعها شنو زايد. فعندنا 3 type، لكن هذا just to understand the basic what does mean compliance. وقلنا احنا ال RDS your compliances go down، وفي chronic lung or restrictive lung disease or restrictive lung disease or chronic lung disease usually you have higher resistance. It become more stiff. وقلنا الفاكتورز اللي affect compliance عندك دلتا في اوفر دلتا بي. شو معناتها؟ معناتها اذا كان الكومبلاينس متاعك is not good you need higher pressure to improve. يعني compliance it's inversely related or reverse with شنو with the pressure. معناتها اذا كان الكومبلاينس متاعك not good you need higher pressure in order to deliver the tidal volume. إذا كان الكومبلاينس متاعك very good you need شنو in order to deliver tidal volume you need a little bit pressure because your compliance is very good, then the pressure you don't need higher pressure. And that's the only if we're going to talk about compliance, that's what I need you guys to know. Also we cover this one as we from the first time you look at, you ask yourself what's the y axis, what's the x axis, that's the pressure, that's the volume. And you can see it does not start with 0. That means that's not under spirometry. That means there is always a beep. Start with a beep of 5 or whenever the beep you set. So that's the inspiration all the way to this point, and that's called peak inspiratory pressure, and that's called expiratory phase, inspiratory phase. And we said if your line, and that's usually appear on the mechanical ventilation, if your curve came this way, that means the compliance is not good. Shorter the angle, lowest or the lower compliance. If your compliance came back this way, that means your compliance, your baby's lung is improved and your compliance is really, really good. Or sometimes even the opposite side. The same, I don't know what's the curve, but when you look at here, so Y is volume, pressure, always delta V over delta B, so that's called compliance. Okay, and that's the easy, always Y over the x-axis, Y over the x-axis. So you can see there is, that's the normal lung volume compliance. On the set point here, higher the pressure does not, those is considered the alveoli. So you can see higher the pressure does not increase your, does not distend your alveoli. In the zone 2, and that's the normal, small increase in the pressure is going to be higher increase in your optimize your alveoli, and that's the optimal VQ. That's in the optimal level. And when you pass certain points, then higher pressure, minimum changes in your volume. And that's with overexpansion. And if we remember, yes, the last time we talked about, or last week, we talked about the vents. We said if your beak, this one has become beaked like this, that means you are, that's called peaking. If you see it in the vents, that means your lung is overexpanded. The same way here, You can see that's the tiny peak. That's the tiny changes on the pressure, highly change the pressure, tiny changes on your volume. And you can see the on here, you can see the alveoli is over distended. Another concept, it's very important, especially on NIV or mechanical ventilation when you deal with the baby. So in the y-axis, that's the resistance. In the x-axis, that's the volume. Here, there's always a residual volume. And then on the top here, it's called total lung capacity. At the end, there is a remaining, that's called the residual volume. You can see in both ended on your pressure, both sides, either overexpansion or atelectasis, you have higher pulmonary vascular resistance. So that means if you are dealing with a baby, if you are over distended, you increase your pulmonary vascular resistance. If you are under inflation, that means, or atelectasis, your lungs collapse, then you increase your pulmonary vascular resistance. The optimal at this curve, in this curve or optimal, it's on the setting when you optimize, that you are on the normal functional residual capacity, where the maximum pressure and with the same time you will get the highest volume. So at this time here, your alveoli as the max VQ mismatch, VQ, not mismatch, VQ. Here we called optimal VQ. Higher you go, higher your pressure resistance. The lower your collapse, your alveoli, it's higher your pulmonary resistance. That means when you are dealing with the baby on the vents or an IV, it's not good to overexpand and it's not good to underexpand. Always you will keep it in the midway at the functional residual capacity. Okay, the last time Dr. Ayman, he asked me, I think he joined us now, he asked me about the oxygen and what effect on the oxygen. I'm gonna cover it very quick here and hopefully in detail. There is two different terminology I need everybody to be aware of. There is hypoxemia and hypoxia. There is hypoxemia and hypoxia. When we said hypoxemia, that we are asking or we are looking on the PaO2 or oxygen saturation in the blood. How much the oxygen in the blood. Hypoxia, we are talking about tissue perfusion, tissue oxygenation, sorry, at the oxygenation at the tissue level. Hypoxia versus hypoxemia. Okay, hypoxemia frequently as a result of hypoxia, but doesn't mean that if baby hypoxemic is not always mean you have tissue hypoxemia or hypoxia, sorry, or opposite. Okay, so there's two different terminology. Hypoxemia, saturation or the PaO2 or how much the oxygen in the blood. Hypoxia, you measure the oxygen at the level of the tissue level. Okay, there's factors affecting the oxygen delivery or tissue. Now we are talking about hypoxia. What's the factor that affecting your oxygen at the tissue level? I'm not talking about hypoxemia itself. I'm talking about at the tissue level. Number one, we said the PaO2, arterial oxygen. Okay, your oxygen tension in the arterial blood. The second factors is the hemoglobin. The third factor is your cardiac output. How is important? If you have baby shocked, then despite he has good oxygen, despite he has normal hemoglobin, if he is septic shock or he's hypovolemic shock can affect your hemoglobin, but if he's in septic shock or cardiogenic shock, then he's gonna have the tissue hypoxemia. Despite if you have a baby who has the PDA, let's talk about it very quick. That's the heart, and that's the pulmonary aorta, and there is PDA here. And the pulmonary connected to the, here there is lung. There's the right atrium, right ventricle, left atrium, left ventricle, pulmonary circulation, superior vena cava, and superior vena cava, inferior vena cava. So if we gonna talk about PDA, why it's important to know this? Because if you have a baby has a large PDA, what happens? He's supposed to be pumping 100% blood coming this way. If the baby's blood starts healing left to right shunt, what happened to the perfusion? Your perfusion gonna decrease, correct? So although the cardiac output is normal or might increase, your perfusion is decreased. And that can lead to the tissue hypoxia. The cardiac output is decreased. The amount of blood go to the entire tissue is decreased. So that's we understand this one. So there's multiple examples for the decrease the output, how they affect the tissue oxygenation. Okay. Hemoglobin. If your baby anemic to the certain point, sometimes you have baby anemic, and then he required higher oxygen. Then you ask yourself, okay, my baby is, what's going on with my baby? Why he's required very high oxygen concentration? Look at your sitting, look at the lung, everything looks, you're giving the optimal. And then one of the things you need to consider is that what's the factor affecting my tissue oxygenation? The heart, does he have any issue? Does he have any PTA? Does his contractility of the heart looks normal? What's my hemoglobin? Because if my hemoglobin is low, if the baby anemic, then the tissue perfusion is decreased too. So that's there is correlation. Then in this case, you might need to transfuse your baby. And there is criteria for when you transfuse the baby. One of them, if the baby mechanical ventilation required higher oxygen. There are certain goals. So there's baby room air, you are okay with even 24, 25, 23 hemoglobin or hematocrit, sorry. If your baby on the mechanical ventilation and required higher oxygen, even 30 or 35, you might consider transfuse your baby. You understand the difference now. So you have 3 factors affecting the tissue oxygenation. That's what's important. Not only you're looking at the hypoxemia, you are looking at the hemoglobin, you are looking at the cardiac output. Those 3 factors affecting on my baby's tissue oxygenation. It's very important. I think this equation, every neonatologist, he has to memorize this one. That's highly yield board, okay? Oxygen delivery content, it's 2 factors affecting my oxygen delivery. Cardiac output and my arterial oxygen. In other way, the cardiac is easy. The oxygen content here, oxygen content. If you take this one is equal to 1.3 multiply hemoglobin, multiply oxygen saturation, multiply 0.01. So this one and this one, you can make it 1.03 plus 0.02 multiply your PaO2. Okay? You don't have to remember this. You don't have to remember this. What I needed to remember, it's the oxygen delivery, it's equal to cardiac output, multiply hemoglobin, multiply oxygen saturation, plus 0.02 multiply my arterial PaO2. Again, let me clear it up. So it's going to be very clear. And then I will explain why it's important and what's the clinical value for this one. So cardiac output, that's one parameter. Multiply your hemoglobin, multiply your saturation, the oxygen saturation, plus 0.02 multiply your PaO2. What does it mean? If you guys note, I don't know in the Libya how you but most likely going to be the same because I know, mashallah, there is a lot of the good physicians there, expertise. So usually when we deal with the NICU, we are looking on the oxygen saturation. Did you guys hear about very, 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 very few cases we request to do arterial and looking at the PaO2? Most of us now, when we deal with tiny babies, very rare we are requesting the arterial gas. Usually we do the capillary gas and we don't even pay attention to the PaO2. We are looking on the oxygen saturation. So when you are dealing with the oxygenation, we are looking, majority or almost all of us, we are looking at oxygen saturation. Why? Because of this equation. What's affecting my oxygen delivery? Cardiac output, hemoglobin, it's important, and oxygen saturation. What about this? This one, whenever the number here, if you multiply by 0.02, it's going to be 0. Almost. Very rare, it's going to be point. So if you have PaO2 is 200, multiply by 0.02 is going to be none. So that's why very, 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 very rare, very occasion cases, we're looking at the PaO2 We always pay attention to what? My cardiac output, number one, hemoglobin, and oxygen set. Those three parameters. In oxygenation, I look at the number one. We said, correct? We said number one, the saturation. That's affecting my oxygen, the oxygen. How much hemoglobin saturated with oxygen. My hemoglobin itself, the carrier for the oxygen, and the pump, the cardiac output. So you have three, either the pump or the car that is going to carry the oxygen, or how many seats left, the saturation. Okay? Is that clear, inshallah? Okay. We said on oxygenation, the various or the parameters in any vent baby, either NIV or mechanical ventilation, you have the FiO2 and you have the delta B, or the mean airway pressure, which is mainly the beep. In tiny baby, we have a certain limit for the beep. After that, we are going to the PIP, or if we are using the tidal volume as a volume guarantee mode. Okay. The that's the pressure, correct? And there is others, little about I time, about the, mainly I time. Okay, so those parameters. For the FiO2 part, it's very important. That's usually controlled by the nurse, correct? So you said, I need my baby saturate, sorry. I need my baby, so you said the number of the goal, saturation goal. And I told you, like, for example, I need my saturation to be 89 to 92, just example, percent. That's my oxygen saturation. So the nurse, she controlled the FiO2. We have something called the blender. I realized that Libya, there's no blender there. So blender, where you control how much oxygen. It comes from the wall as 100%. The 100% from the wall connected to the blender. The blender has room air 21% to the 100%. So you control how much oxygen you need to deliver to the baby. They called blender. Okay, so the nurse, she has the control of this. We are not under control of this one, the nurse. So when you come and round in the baby, or you do during the night round, or from time to time you see your baby, if your oxygen went up, for example, from 21% to the 50% or 40%, just pick number, then you know you don't want this oxygen. You need to think, what's going on? I need to make adjustment so my baby does not take in 50%. Few cases, unfortunately, we cannot. If there's infection, you cannot, because that's affect the perfusion. If there's infection, that's the alveoli, and that's the capillary. If there's infection that's affecting your perfusion here, it's very hard. So even with the stretching, and we try to give and there's inflammation here, sometimes it's very hard. So unfortunately, you need to adapt it. But majority of time, or a lot of time, you still have a control. You can control your vent setting in order to decrease oxygen. Why? In adult, doesn't matter. In adult, in fact, they start with 100%. In babies, even in resuscitation, we start on the 21%, unless premature baby, you can go up to the 30% at the set point. So it's in premature baby from 21 to 30%. In full-term baby, usually we set 21%. That's the starting resuscitation, okay? And then you go off your baby, and we have the saturation goal in front of us. And then, for example, at 5 minutes, you need your baby from around 85 to 80 to 85. I don't remember exactly those numbers, but there is always in each delivery room, there is a set goal saturation. And then you resuscitate, and your eyes on the saturation, make sure that you don't want to go up, especially the beginning. Baby does not require oxygen. So you don't need to start on 100%. Why it's important? Because oxygen, it's to the certain limit, our body can handle it. In certain limit, our body can handle it. Full-term baby, better than preterm baby. But when your oxygen increased, it's released something called the oxygen free radicals. So your oxygen free radicals start released. What are those? You have the oxygen superoxide, hydroxy radicals, hydrogen peroxide, and the hydrochloric acid. Your body has ability, so those oxygen give you oxygen, hydrogen superoxide, hydrogen peroxide, and then break it down to the hydroxy radicals, and then hydrochloric acid. Should be Cl, or here's water, but usually it's going to give you hydrochloric acid. Okay. Under normal circumstances, I said your body can handle it, but premature baby, they cannot handle excessive amount of oxygen. So how our body handle it? By the glutathione as an antioxidant or other antioxidant, catalase, superoxide dismutase, vitamins C and E. And in fact, I don't know if you guys are aware, bilirubin also, it's considered as an antioxidant. That's why we don't make the serum bili 0. We always keep it on the normal threshold because it's considered as an antioxidant. Okay, so bilirubin is antioxidant. Certain level, it's normal. That's what we would like to keep it. But if it's high bilirubin, then we say, oh, no, it's dangerous on the brain. They can cross, especially the unconjugated one, can cause blood-brain barrier and cause connectors. So in certain level, it's considered as an antioxidant. It helps breaking down those free radicals. But if your oxygen increase, what happens? It's gonna damage the cellular at the cellular level. So number one, it's gonna affect your lipid peroxidation. So it's gonna damage your lipid peroxidation, allowing the calcium, variability of the calcium enter the cells, and then it can affect your mitochondria. Also, as all proteins, oxidation, degradation, DNA also damage. So that's the oxygen can create inflammation. And in fact, one of the factors for chronic lung disease, it's the high oxygen. So oxygen toxicity can affect or can cause chronic lung disease. That's why we always try to minimize the oxygen affecting on the baby. Okay, enough physiology. We're gonna go now to the non-invasive ventilation. So non-invasive ventilation, we have high flow nasal cannula. We have CPAP. We have bilevel or nasal cannula. Let's take it instead of the high flow. We'll say nasal cannula. Nasal cannula, we have low flow nasal cannula. And I think we discussed this one, but just repetition, high flow nasal cannula. The difference between high flow nasal cannula and low flow nasal cannula, the amount of the flow. If you are giving less than 1 liter per minute, that's called high flow nasal cannula. Anything above 1 liter per minute flow, that's called high flow. If you give more than 2 liter per minute, it should be, we said, number one, heated. Number two, humidified. Number three, so heated to the 37 or 36 degree, humidified to 100%, heated, humidified, high flow, which is flow more than 2 liter. More than 2 liter. So centers that they have respiratory therapists, usually if you order 2 liter or 3 liter, nobody will ask you whether heated or humidified, because that's the automatically they're gonna come and they're gonna set it on the heated. If you are dealing from 1 to 10, from 1 liter to 2 liter, usually they're gonna come to you. They said, hey doctor, do you want it heated, humidified, or do you want it just dry? Then you can decide it, okay? So that's clear, inshallah. Low flow nasal cannula, usually we use it as a transition from the high flow to low flow in baby with chronic lung disease. So usually we don't, and I never hear somebody who starts on low nasal cannula on the baby or premature, or we don't use it, okay? Or full-term baby low flow nasal cannula 0.5 or whatever, no, we don't use it. So this one usually weaning mode from the vents, from invasive to non-invasive, from non-invasive CPAP to the NIV, to the nasal cannula, from nasal cannula high flow to the low flow. That's the way to go, okay? You try give him from CPAP to Romer. If he failed, then you know that he's most likely is going to be chronic lung. Then you transition to the high flow nasal cannula and then to the low flow cannula again. So if you have baby, when he's 23 weeker, or for you guys 25 weeker, 26 weeker, you place him in vents and then extubate it to the CPAP. And then from CPAP, he remain under 32 weeks. That's most fast do. And then 32 weeks, try to give him Romer, try to completely turn it off. If he's good, then you're done. If he's not good, then you know that he needs something. He doesn't need CPAP, but he might need step down. Then you can switch him to the high flow nasal cannula. And then start with 3 liter, 2 liter, and then go all the way to the 1 liter. And then when you reach 1 liter, if he still required something, either oxygen or flow, then you might wean down to the low flow nasal cannula. And if we decided to send baby home, usually we send baby home on because he's going to be on oxygen tank. So usually we send them home on the low flow nasal cannula. واضح? Okay, so high flow nasal cannula, we discussed. There is we discussed about this, and we have something called Vapotherm. It's the mobile, doesn't connect with the wall. It's the fancy machine. It's the same heated high flow nasal cannula, لكن it looks like CPAP machine, or it looks like it's very fancy. I will show you the picture later on, but the same principle. Nasal CPAP, how you deliver CPAP, either through the Neopuff, we're going to show what does mean, bubble, infant flow, or infant vent, sorry, infant vent and infant flow, we will discuss. And then we have bi-level, اللي هي NIPPV, or non-invasive intermittent positive pressure ventilation. Either through the Neopuff also, or infant flow, or vent, sorry, or infant flow اللي هو يسموه فيها CPAP. Okay, so again, heated high flow nasal cannula. هذا البلندر you can see has a gas source. الفلو هنا في اللي هو 1 2 3 4 5 هذا الفلو. You set what's the flow you wanted. 1 2 liter 3 liter whenever you want. Connected. هنا في water for a humidifier and heated same time. Heated يطلع لك humidifier. وهنا في شنو measurement the temperature, reading how much temperature, and that's come to the interface اللي هو شنو اللي هو النازل كانيولا ولا opti flow ولا different الانترفيس. الفرق بين الهاي فلو وهذه is very important, this is number 5. الفرق بين high flow والسباب في النازل كانيولا itself البرسنتج اللي هو الكفر النوسترلز. اذا كان بتستعمل الهاي فلو نازل كانيولا المفروض تكون less than 50% of the nostrils، يعني تكون صغيره بحيث ان تكفر just less than 50%. هذه لو كان انت تستعملها كهاي فلو. اذا كان بتستعمل السباب لازم تكفر at least 70 or 80% من nostrils. واضحه؟ يعني هذه الفكره الهاي فلو نازل كانيولا. الفيبوتيرم as I told you, it's fancy machine, has a just cable to connect the wall. لكن everything is here. It has 7 liters per minute. It measures here the temperature. Sorry, the oxygen 27% and the oxygen temperature 37 centigrade. And that's fancy, expensive. Not a lot of centers they have it, so it's not even available everywhere. The advantage either high flow ولا الفيبوتيرم إن هي minimal tissue injury لأنها humidity وheated. Kids they like it. It's not like CPAP is more pressure. This one is doesn't have delivered pressure, but we don't measure the pressure, so it's more comfortable بالنسبة للبيبي. Baby tolerated better. A disadvantage خاصة في premature baby, we don't know how much CPAP or pressure we deliver. So that's the issue with high flow, or so this one heated high flow nasal cannula or Vapotherm, the same. Okay, the same advantage disadvantage. Again, it's more used for full-term baby or step-down premature babies. علاش ما نفضلوش استعملوها في premature baby؟ لأن we don't know the pressure, we don't know how much, because premature we know that baby has issue with compliance, so we need to remain the intra-alveolar pressure high, so we need to know how much pressure I deliver to my baby. So that's why usually it's step-down or full-term baby you can use it, because your concern is not about compliance. الانترفيس, so that's the Hudson nasal cannula. هذه تقريبا متوفرة في ليبيا, you can see it. هذه اسمها OptiFlow الكمباني. اوكي, so OptiFlow. الOptiFlow ميزتها ان فيها الكويل. هذه الكويل الهيتد, فيبدا الووتر كوندنسيشن ما يجيش ويوصلش للعين, لان المشكله في خاصه في الرام كانيولا we will talk about it later on. مع الهيتد humidified heated high flow الووتر يبدا كوندنس وينزل عليه الخشم ده العين, يبدا irritation, يبدا discomfort. This one it's the coil, فيجي شني heated humidified without شني الووتر, يجيش condensation water in the baby's nose. Okay. In Julian history, people they look at the CPAP versus high flow nasal cannula versus vents. What I need you guys to look at the two lines, the yellow one, and the red one. You can see the CPAP since 1997, it's the same. People, they use sometimes more than usual, a little bit higher and then decrease, and then, so it's almost constant line. They always used. But you can see the high flow nasal cannula, the red line, since 2000, introduced in 2002, people, they start more often used in the NICU, okay? Some centers, they لأن البيبي comfort, they immediately baby when the baby around 30 weeks, around that range, or if you have a gas on baby on CPAP and the gas CO2 came back low, then people, they switch into the high flow nasal cannula. And some centers, they use more high flow than others. So it's variation. Again, some people, they already approached me from the beginning. I told you the NICU is different variation. Some people, they use this one more, and we will hear from different physicians. If they join me practice in different areas, they will let us know, but every place is at difference. In my practice, usually I let the baby on CPAP till 32-week gestation, and then after that, try to room air. If it doesn't work very well, if he starts retracting, then I step down to the high flow nasal cannula, and then slowly challenge again. If it doesn't like it, it's still retracting, then low flow nasal cannula. الريزن لأن في study look at the CPAP, let the baby longer on CPAP, improve long-term lung compliance and decrease chance of the chronic lung disease, asthma. So the CPAP is very good for even for the alveolization and the lung growth and development. People, they try to look at the heated high flow nasal cannula versus nasal CPAP as an alternative to nasal CPAP. They try to measure the pressure inside, يحطوا في small probe transducer here in the distal esophagus, and they measure exactly the pressure. 40 babies, that's 2001 study on 40 babies, high flow at the 6 liter versus beep of 6. They found there is no difference between 6 liter high flow nasal cannula and 6, that's based on the pressure. There's no difference in the pressure at the distal esophagus. Also, there's 2016, although it's pilot trials on 18 babies. You can see most of them is bigger babies. This one, 28 weeks. They tried 3 to 5 liter versus 6 liters, and the same issue. They blow the catheter to monitor the pressure, and they found there is no difference in increase in both difference between nasal CPAP and high flow. There's no difference between the pressure. There's another study, 2014, and also pilot trial, 12 babies. They tried to different high flow, 4 liter, 6 liter, 8 liters versus 4, beep of 4, beep of 6, and beep of 8. And also there's almost as equal as a nasal CPAP. Okay, and ED, that means end distal pressure measurement. Nasopharyngeal pressure also measured, and you can see higher the flow. So this one, it's the flow, the X flow. Y-axis is the mean pressure, okay, or nasopharyngeal pressure. You can see higher you go on the flow, higher you deliver pressure. So you can see if you're gonna look at a 2 liter, how much pressure generate, the same line. If you go up to 6 liter, you generated higher pressure. But you can see it's the variation from one study to another study. There's no, you can see there is study 2008 versus, so those lines is different study. كل study has different variation. فيش consistency. لأن يعتمد حتى عليه الانترفيس, what they are using. People not only look at the flow or pressure, difference between high flow nasal cannula and CPAP just on the pressure. They look at also the comfort level and the pain and discomfort between the nasal CPAP and the high flow. And the conclusion, it's controversial and that's more subjective. So that's we cannot conclude it. They also said, hey, in the NICU, we know that noise itself can cause hearing loss. Anything exposure, according to the American Academy of Pediatrics, anything above 90 decibel noise can cause hearing loss. And the recommendation to avoid, the recommendation from AAB to avoid anything above the 45 decibel. That's the noise level. So they measure the noise level between generated from high flow nasal cannula versus nasal CPAP. And they found both the study, there's few studies they look at, and those studies they found there is no difference in the noise level between both nasal CPAP and high flow. And interestingly, couple of the units that I practice or work, they have noise measurement. So when you enter the especially small baby unit, we have a small baby units where we are dealing with less than 32-week gestation, small unit حاطين مع بعضهم. وهني اول ما تدخل يونت تلقى فيه زي الترافيك لايت. When you round or you talk to the nurse, if your sounds go above the recommended, is turn red. That means slow down, decrease your voice. And the same time, if it's green, that means you're good. If it's yellow, that means yes, you're still good, but be careful. So at least people, they try to put it in the areas where they are dealing with my tiny babies to avoid the hearing loss. Okay, so next we talk about high flow, heated high flow. We covered in detail, inshallah. If anyone has a question, we will discuss later on, but please write it down, your questions. Julie, Neopuff. Neopuff, I'm not sure, Dr. Ayman, do you guys have a Neopuff infant resuscitator? Dr. Ayman.
Hello, Dr. Ayman Ayat.
Do we have
Neopuff, I don't think so. I never used in Libya. I used outside Libya, but I never used in Libya.
Okay, so Neopuff هذه توا replaced الامبو باج والانستيزيا باج اللي هو السيلف انفليتد باج ولا الفلو باج. هذه deliver constant beep، وهذه في كل تقريبا امريكا تلقاها متوفره في كل الرومز، الدليفري رومز، وحتى حتى في الايزوليت connected with the isolate اذا كان emergency you need it. So هذه سموا فيها Neopuff. Let's go in details since you guys don't know. Good opportunity to explore. So we said this is the cold blender. Number A, it's the blender. Has the here room air 21%, here 100%, and you have the way to control it. Okay. دكتور هوائي اللي عنده نقال بالله silent. Mute the phone please. اوكي، بالنسبه لهذه اللي هو الفلو، في العاده نبدو بنحطه على 10 لتر فلو. اوكي، هنا تلقى هذا طالع منه ماشي all the way come here and that's called the T-piece. كانت تشبه هنا فيها في العاده ان هذا تتحكم في اللي هو يسمى فيها البيب كاب، انك تتحكم في البيب how much you need beep. في العاده اول ما يجي قبل ما يطلع او deliver baby we lock this one, we put our hand here and then we look at how much the monitor here measure the beep, and then we adjust the beep how much we need it. Usually we start at the beep of 5 to 6. Okay, depend. And here you control the PIP. So if you press here, if you press on top, you generate PIP. If you don't do just put the face mask, you generate beep. Make sense or no? So the cap is just when you twist it, you monitor how much beep you need. But once you put your finger on top, that's generate PIP. So you take your finger in and out, in, out, in, out. You touch the cap, that's generate the PIP. Okay, that's in brief. This one you can deliver constant beep, and also so that's the CPAP or constant beep, or also you can deliver شيء اللي هو إذا كان baby apneic, you want positive pressure, then you can put your finger here and just in and push out, open, enter, like just cover the cap in and out multiple times like this, 1 and 2 and 3 and 4, 1 and 2 and 3 and breath, 1 and 2 and 3 each time. So if you do like the CPR, then we said 1 and 2 and 3, and then the nurse or the physician or nurse practitioner, they make chest compression and you deliver PIP like this, okay, in my finger. Okay, so as I said, this one you can deliver PEEP. If you are in the tertiary, like small like small hospitals, you don't have the CPAP machine. Usually they leave the baby on the Neopuff CPAP until we come over, and then we took the baby. Okay. شرحنا advantage of the CPAP. So CPAP is the main advantage of the beep is to recruit the alveoli and prevent atelectasis. You're gonna stabilize also the chest wall and upper airway, maintain the lung volume the same way, and then it's gonna be like this, okay? And then you reduce the work of breath and you improve, okay? And you promote your surfactant release. So the whole idea of you having, if you have the alveoli is very unstable, and if you guys remember, okay, so we have the unstable alveoli and we have very stable alveoli. If unstable alveoli, you need to retain to make it more stable by delivering shini PEEP. So first, you recoil your alveoli, because without surfactant, your alveoli is very recoiled. The wall is easy touch each other and it's very sticky. Once touches us, it's hard to open. So once you recoil the alveoli, then it's gonna allow the air or the tidal volume to come in, and then baby is gonna relax. So it's gonna slow down because you improve minute ventilation, again, equal to the respiratory rate, multiply the tidal volume. Once you improve the tidal volume, baby slow down, and then you help the time for the surfactant to start to release. Okay, CPAP, there is, let's go back and explain this one. Oh, no. Okay, CPAP, we have two types of CPAP. We have something called constant flow CPAP, and we have variable flow. Constant flow CPAP اللي هم حاجتين اللي هم الميكانيكال ventilation. So if you have mechanical ventilation, you deliver through the nose, you set your parameters, that's constant flow. Is inspiratory, during inspiration, expiration is constant, same flow, it's fixed flow. Or you have bubble CPAP. Bubble CPAP, we will talk about it, that's called bubble CPAP. You have like the box, any even مدع المية or يعني تقدر تستعملها, it can be أنا عندي link, I have a link at the end of the presentation. I just left it here because it's easy. You can have it in your hospital. We don't need fancy bubble CPAP. You can create it by own. Just you need somebody who's like engineer or technician, he can make it. Okay, here it has the levels. So the water level, you have 1, 2, 3, 4, 5, 6, and so on. So like the levels. Heated, humidified, and then connected with the wall where there's blender and flow. That's called bubble CPAP. Bubble because it's the way it's bubbling, that's the name come from. And that's constant inspiration and expiration give constant flow. And then you have fancy machine here that's called variable flow CPAP device. Variable flow اللي هي infant flow, had called infant flow اللي هو السيباب or BiPAP. هذا will have two also, هذه called blender اللي هو control oxygenation, room air to the 100%. Here flow, here the pressure. Okay, and you can see numbers, so you controlled. هذا we will talk about later on. Like in the way it's work, it has difference in inspiration versus expiration. The pressure come inspiration, it's the higher, and then when the baby's breathe expiration, then it give flow, lower pressure or low flow go to the baby. Had a more comfort level, baby they like it more. But fancy is not available everywhere. Okay. Those devices is connected either through the nasal mask, had a nasal mask, or nasal bronch. You can see different color based on the baby size. We measure the nostril, and based on the measurement, it's gonna guide us which color you need to choose. Okay. And then we have the RAM cannula. That's the RAM cannula. You can see the difference between RAM cannula. Number one is bigger, wider, the tube thickness. Number two, it's cover around 70 to 80% of the nostrils. And the connection here, I don't know where is it. The connection here, it's has a connector that can be connected with any mode. of the ventilation. Every mode can be connected with all of them. So it has fixed mode, standard mode, can be connected with any one of those. So it's more friendly use. So that's called RAM cannula. Whose RAM is the Indian guy who's from the University of the South California. He's the program director there. So he's the one who invented this one. And now widely distributed in America. It's very cheap and it's work. Wait, evidence. Several systemic review studies show that CPAP is more effective in lowering mortality, reducing the risk of bronchopulmonary dysplasia compared with intubation with or without surfactant administration. هذا علاش is always, and that's there is meta-analysis study and there is randomized controlled trials. They look, this always confirmed that if you have a baby who's on respiratory distress, premature baby, it's always good to have the baby on non-invasive than invasive. Okay? Do your best. Okay, so we will talk about bubble CPAP. Bubble CPAP, the way it generates the pressure as a bubbling, like high frequency, is go like variation. Okay, so that's the pressure. So if you're gonna look at the y-axis, it's the pressure. Okay, and then the timing, and you can see the pressure generated is like fluctuating. الجود في البابل CPAP إن هو very cheap, inexpensive, and should be every hospital. A disadvantage of the bubble CPAP إن هو there is no built monitor. يعني شو معناتها؟ The only way to know that it works by looking at the bubbles. It's not gonna alarm if the baby lost the interface. And that's why if you're using nasal mask, once the nasal mask is lost, then stop bubbling, baby's desat, and you're not aware. That's why that's very tricky. We use the RAM cannula or nasal bronze, there's no issue, very unlikely the baby is gonna lose the interface. But if you have the nasal mask, then it's might be an issue. Because once it's off, the only way to know if the baby starts desats or apnea, then you know there's something wrong. You look at the baby and you come and see. And sometimes that's potential for increased work breath. That's why you need to be careful. The way it's work with the bubble CPAP, you need to set the flow and you need to set the beep. So you said usually the same. So you said I need 5/5. That means 5 flow, 5 pressure, or 6/6. That means I need 6 flow, 6 pressure. If you need to increase let's assume that you are 5/5. There is no bubble or baby a little bit start retracting. You don't want to go up in the pressure. You can go up in the flow. So you can see here that's the pressure on the y-axis, and you can see the flow on the x-axis. Start with 4, 5, 6, and you can see on the ventilator, the blue line versus the bubble. And you can see in the ventilation is the fixed constant flow and constant pressure. Versus bubble CPAP, yes, it's constant flow, but you can control it. You can increase it. So you have the parameter, you have the ability to increase it. So if you increase your flow from 4 to 6, slightly your pressure is going to be increased. If you increase your flow to 8, from 6 to 8, you can see your pressure slightly increased from 6. So that's called bubble CPAP. It's become widely used in America after Columbia Hospital. Then at Columbia Hospital, they have the lowest chronic lung disease rate at the time. Everybody say what's going on, what they use different. The physician, they are very good. They have use bubble CPAP, and they adopt, they called passive hypercapnia, a little bit higher CO2, and they are aggressive not to intubate the baby. نجول السكند تايب اللي هو الكونفنشن CPAP. It means the mechanical ventilation. The advantage in everybody comfortable to use it لأنه it's been for years now. Everybody can use it, so comfortable level is high with the caregiver. The variable flow CPAP, you see how fancy, how beautiful look. Okay, expensive. The way it's work إن هو during inspiration it has flip. So during inspiration, the flow is go and does not interfere with the baby's breath. So babies take a deep breath, is take together. During expiration, it has a flip. So it's come out and does not interfere with the baby. So it's more friendly use. It has a monitor built in. So it has freestanding system. So it's easy to manipulate work. Internal monitor, that's good. It's synchronized better with the baby than اللي هم others اللي هو الconventional CPAP ولا bubble CPAP. الإيشو إنه هو شنو upfront cost. نجوا لي الكيرف اللي شفناه في المونيتور. بالنسبة للبيب هذا اللاين اللور، هذا البيب هنا وهنا اللي هو الباي ليفل. You can see beep, it's the 5. Sometimes baby's breath against it, so sometimes up, sometimes down, but you are delivering enough to retain the residual volume or to keep the alveoli open. In the bi-level, we have either BiPAP or CPAP, synchronized, or we have NIBBV. The difference is a little bit minor difference in pressure. You can see here, BIB 5 and BIP is not as a normal we do 20 or 25. This one is the mean airway pressure. It's the usually around 8 to 10. Okay, and you can see during inspiration, the BIP, and then expiration, inspiration and expiration. Okay, that's the bi-level. That means there's 2 levels. You have a BIP, peak inspiratory pressure, and you have the beep, you want positive end expiratory pressure. So you have bi-level. That means there's 2 levels of the pressure set. And we said CPAP, it's usually we use the mean airway pressure and the beep. In IBBV, we set as a vent, usually higher BIP, اللي هو 20, or we can go up to 25 or 30. At the intra-alveolar pressure is the same. That's baby's breath normal. So you can see around 0, a little bit up and down. Once you put the baby on the CPAP, you always start with higher. So there's beep, but you can see also variable with inspiration expiration. In the baby on the bi-level or in IBBV, or usually you set the BIP. So this one we know that in IBBV, okay, so 18 whatever here number, okay, and then expiration, inspiration, expiration. And here the beep always doesn't start with 0, start with the whenever 5 or 6. Advantage of the non-invasive إنه هو offer benefit of mechanical ventilation without intubation. You have the PIP, you have beep, you have rate, you have eye time, and usually we use it as a last resort. So what does it mean? You place baby on CPAP, premature baby, CPAP. If he still doesn't work and he's up on oxygen, and you know that doesn't work, then you might try NIV, NIPBV, before you intubate your baby here. If your baby improved, then you save the baby from intubation. Reduce need for sedation. Baby comfortable, you don't have to place the tube, because once you intubate the baby, sometimes baby doesn't like it, they're gonna fight with you. Okay, here it's baby comfortable, you give it to the nose, so you don't, it reduces stress level. And there's always risk of chronic lung disease on babies on intubation. You always damage the lung when you intubate the baby. There's high risk for that. Your baby go to the chronic lung. Or there's high risk of something called VAB, which is ventilation associated pneumonia. The longer baby intubated on mechanical ventilation, high risk for infection. Okay, we call it VAB infection. In an IV, less likely because there is no foreign body inside. When you consider the NIV, either CPAP or NIBBV doesn't work if you have baby completely apneic. Either apneic or septic shock or any condition that baby has no spontaneous breathing, then you need to intubate the baby. There's no way the baby is completely apneic. There's no way that NIV or again, it's very unlikely. If it's apnea very short and you wanna overcome with just switch him to the NIV with the rate, that might work. But if baby has secondary apnea, or if baby, usually secondary apnea, then it doesn't work. Okay. If you have baby with facial trauma or facial malformation, cleft lip and palate severe, then there's no way to leave the nasal mask or nasal bronze or RAM. So in this case, you need to intubate your baby. The third contraindication, if you have a baby suspected diaphragmatic hernia, you don't want to blow air in that, because in diaphragmatic hernia, what happened? That's the lung. And here, your esophagus. So in diaphragmatic hernia, your organs, everything is up in the lung. You don't want to blow air that might go to the lung, might go down to the stomach and increase the tension in the organs, either stomach or the bowel, and that's cause more pulmonary hypoplasia. You don't want that. So once you are highly suspicious baby with diaphragmatic hernia, or you have very good antenatal center where they can diagnose diaphragmatic hernia antenatally, then this baby immediately need to be intubated. Make sense? Very good. NIV, different terminology, bi-level CPAP or BiPAP or CPAP we discussed. We have NIV, we have synchronized or non-synchronized. The synchronized is fancy. It's called neutral adjusted ventilatory assist, or NAVA. Okay, it's neutrally adjusted ventilator assist. This one, in order to work, there's a fancy machine or there's another machine or some sort of ventilation. They provide the NAVA that they have the probe. They go all the way, reach at the level of the diaphragm, and that's the sensor. It senses the movement of the diaphragm. How it work here. So in regular mechanical ventilation, the CNS send a message to the phrenic nerve. Phrenic nerve excitation, diaphragm serial irritation, and the diaphragm start contractions, chest wall and lung start expansion, changing in the pressure. Once the changing in the pressure, the flow and volume inside the alveoli, that's mechanical ventilation, okay, not NAVA. There's flow sensor, it sends message to the ventilation, and then it sends assistant breath to the baby. So that's regular ventilation. This cycle is the regular ventilation. So baby start breath. Once baby initiate the breath, flow sensor to the mechanical ventilation, ventilation sent an assistant breath to the baby. In the vents اللي هو النافا اللي هو يسموه فيه اللي هو neutral assistant ventilation، هذا لا ما يرجيش لين البيبي start breathing. No. At the moment of the diaphragm start irritation or excitation, then it's the neutral trigger, the esophagus sensor, they measured and sent a message to the ventilator to send. So at least it comes at the same time. And that's more synchronized with the baby's breath. Theoretically, this one is better than the non-invasive or the NIBBV, the unsynchronized one, more babies comfortable. There is a lot of data confirm that, not yet. But to start, it's expensive. A lot of places didn't want to switch with the mechanical ventilation until we have more evidence that this one is way better than the other one, or decrease the chance of the chronic lung disease or so. So far, we don't have any clear evidence. But this one is more friendly used, less likely for pneumothorax, because that's the trigger babies and the breath you can assist it other than the other one, the regular mechanical ventilation. Okay, so let's play a little bit about the concept. We spoke about it, mechanical ventilation, but the same concept here. We have the NIBBV, we have PIP, we have a beep, we have a rate, and then we have the I time. Here we have the pressure, and here we have the time cycle, and here pressure, the y-axis pressure, and the x-axis is the time. Okay. Here, beep 5 or 6, whenever the number. Let's choose different color. You start with 5, start generating the first rate, and then expiratory, second cycle, breath, and so. So you can see, oh, sorry, that's not the same boxes. We need to make it so just mistaken, but that should be the same box. Okay. So this one, beep of 5, that's your beep, 20 or 25, whenever the number. The distance between here, all the way here, that's called I time. Okay. The box or the area here, sorry. The area here inside the box, that's your tidal volume. Okay. And that's the whole cycle. So that's the one rate. That's the second rate, and so and so. And we said, in order to improve, if your baby has an issue with oxygenation, what the initial setting of the vents before we talk about it. So usually we start with the 20/5, rate either 30 or 40. I time, usually longer than intubated baby, usually 0.5 to 0.6. Okay. And then you can increase it. So beep of 20, beep of 5. So we call 20/5, rate 30 to 40. You can start whenever, and then you can increase. I time 0.5, usually. You can increase to 0.6. That's the starting point. Let's assume you have a baby. I'm gonna take this one out. If you are dealing with oxygenation, then the parameters, either the nurse can adjust the FI2, but again, we discussed why we don't want a higher FI2. For us, we have the delta B. So anything above inside the box, that's what you need to improve it. So let's assume that you need to, I need to improve oxygenation by improving my delta B or the tidal volume. So tidal volume inside the box. How can I make the box better? We said, number one, if the baby initially RDS, if you are dealing with the RDS, then you might think, okay, my pressure beep is low. Then you might go up in your beep from 5 to 6. That's because you need to recruit the alveoli. So at the beginning, recruitment. So the beep, number one, you might go up in the beep. It's just because the idea of recruiting the alveoli. If you are reaching the point where hyper expanded, then decreasing the box, that's increase the tidal volume. So decreasing beep from 6 to 5, that's increasing the area inside the box. That's in case of overexpansion. The second way, by increasing my beep from 20 to 25, just increasing my beep, or 22, and usually by 2 or even 5, it depends on the, but usually by 2, 20, 22, 22, 25. That's helped me because I'm increasing the area inside the box. Sometimes, very rare, we might go up on the, especially in the chronic babies, we might go up on my I time to widen my boxes. Okay, so those for the oxygenation. Regarding the ventilation, so the oxygenation, which one we look at our oxygen saturation. We discussed early, for who joined late, that usually they look at oxygenation by looking at the oxygen saturation. Very, very rare we look at the BaO2, and we explained why. In order to improve my ventilation, how can I know my ventilation there's issue? By looking at the gas, the BCO2. If my BCO2 is high, I know we are under ventilation. If my BCO2 is low, we are hyperventilation. And we said in premature baby, we aimed the CO2 a little bit on the high side, 55 to 65, as long as your pH more than 7.25. More than 7.25. Permissive hypercapnia. If your CO2 is high and the baby has respiratory acidosis. So how we know respiratory acidosis? High BCO2, sorry, low pH, that's number one, acidosis. Then high BCO2, that means respiratory acidosis. So if your BCO2 is high, then you have number one, rate, go up on the rate. It's helping blow up the CO2 or blow out the CO2. Number two, and that's the, I'm talking about NIBBV. I'm talking about NIBBV, okay? So NIBBV, there's no, we are using the pressure mode. Or by going delta B, and you are going up on your PEP. Okay, so for ventilation, we're controlling the rate, number one, usually. Or if you have oxygenation and ventilation, then you might move up your, go up on your PEP, can improve both. Make sense? Very good. The difference between NIV and CPAP, there's any evidence? It's remain unknown. Which one is better? NIV versus CPAP, nasal CPAP, okay? I'm talking about non-synchronized CPAP. There's Cochrane trials, the Cochrane meta-analysis trial, that's very good database. They collect the most values research that has true result. They, any bias, any weak research, they take it away. And then they usually, they come with conclusion. And their conclusion is NIV reduce the incidence of extubation failure. That, what does it mean? If you have two microbremy babies, one you place them on the CPAP, and the other one you place them on an NIBV, sorry, NIBV, the chance that your baby failed extubation higher on the CPAP than on an IV based on their conclusion. So if you have tiny baby, you rather place extubate the baby on an IV first than on CPAP to increase the chance of the successful extubation. What about the risk of chronic lung disease or mortality? They said there is no difference in chronic lung disease and mortality. And the last, or in the RDS, we said there's only two drugs that we use among all drugs that we use decreased chance of the chronic lung disease are caffeine and vitamin A. That's the only two medication that's proven decrease chance or risk of chronic lung disease. Steroids, Lasix, diuretics, all what we use, none of them reduce chronic lung disease. The only two proven is caffeine and vitamin A. And just a reminder so we can remember. This is the app online, YouTube. You can guys watch it, especially for those administration, they want to improve the unit. If they don't have the bubble CPAP, they can make their own CPAP. Bubble CPAP, this is the way they explained here how to use it. Okay, so I'm gonna stop here. I'm gonna let see if anyone have any questions, and I'm ready to answer, inshallah. Thank you very much.
بارك الله فيك دكتور أيمن، شكرا جزيلا. هنشوفوا إذا كان في أي أسئلة. اسمع فيها دكتور أيمن؟
إيه تفضل تفضل. I'm waiting.
تمام، خلينا نشوف إذا كان في أسئلة.
هذا خليني أسألك أنا أيمن أموال.
يلا هاي.
What's your target FiO2? Just يعني like for the people يعني التارجت يعني تخليها مثلا انت نشبه فيك تكتب 89 to 92.
That's you mean saturation?
The target sat. Sorry, I said target.
So target saturation. If you look at the most of the textbooks, 90 to 95. In my center, we have higher ROB. Even in my training, we aimed a little bit lower, so we used the 89. انت ما لحقتش احنا اتكلمنا عليه الموضوع ده 89 to 92. لكن 89 to 92, yeah. Most of the places 90 to 95.
Yeah, we use 1995 because one of the Cochrane meta-analysis study compare low sats like 85 to 89 comparing to 90 and 95. So the conclusion was decrease the risk of PPD and the low sats, but actually the mortality and the incidence of necrotizing enterocolitis is higher in the low sats group. So we use the high sats like 90 to 95. Even if you Martin van der Roof recommend 90.
ممكن انت ما لحقتش we talk about this one. So you're talk about there's a big study. They look at the low sats goal, and we mentioned this one. It's the 85 to 89, and the high, yeah, and the high sit is the 95 to higher. Okay. And no one look at still there is no evidence which the best target. Just for everyone know, there is no evidence. Whenever I went to the multiple conferences, there is no evidence. We don't know exactly what's the best saturation goal.
Absolutely.
Yes. So the only evidence that we have, higher oxygen or higher sats oxygen, if you leave your baby on the higher sat, you are increase risk of the ROB. If you are aimed to be very low, which is 85 to 89, you increase in mortality. But from that, in between, nobody look now that there's no big studies look at the 89, 92 versus 90 to 95. Although most of the textbooks, they recommend 90 to 95, but no one. And I went to the conference where this big guy, big name, he invested entire his life on the saturation. And he said, we don't know yet which one is better. Some centers, if they have the higher IRB, they aim it a little bit in the lower. Some centers, they use the textbook, and which is 90 to 95. That's the variation, but really nobody knows yet. Yeah, I mentioned, maybe you didn't attend the early.
Maybe,
yeah, I spoke about this one, all these, the parameters. Okay.
بس ال OR target sats انت قلت ممكن ما تذكرهاش بس anyway to make it easy the first minute when you have your target sats to make it easy so 1 minute at 1 minute so 1 minute is 60 seconds, right? So your target sat should be around 60 and then you increase 5 each minute. And then by like 5 to 10 minutes, your goal sets between 85 to 95.
So the way I remember, it's easy for me. It's just 5. I pick it 5 minutes because I know early. Usually, it's hard. So 5 minutes, I need my baby to be 85. That's my goal. So I don't jump on increased oxygen. And but that's a good point that every time you start with 65 and then every time you increase by 5.
No, like 1 minute is 60 seconds. So your target is actually 60. It's just, you know, like easy way to remember. Yeah. Yeah. And then increase 5 each minute.
Yeah. I told you like I'm not good to memorize numbers. So usually every OR we have it small stickers where it's mentioned what your goal saturation during resuscitation. You don't have to at least you have something to look at to compare what everybody's same page.
Yeah, just in case if you don't have a chart. Okay, so the third question is how you define CPAP failure?
Yeah, that's we discussed 2 lectures ago on this. So the CPAP failure, that means baby failed on CPAP, required intubation. So that's the broad definition. If your baby failed CPAP, you place him CPAP and failed, required intubation, that's called CPAP failure. The best predicted value for CPAP failure, as we said earlier, like 2 lectures ago, your FiO2, in addition to the whole respiratory stats for the baby, but the main, the positive or predicted value or the most predicted value for the failure, it's your FiO2 at, they said a few hours of life, big study, and the one study they mentioned at 2 hours of life. But in general, CPAP failure means baby failed on CPAP and you required intubation. Okay. Any other question, guys?
Dr. Ayman, I have one question. Regarding when you go to some textbook in mechanical ventilation and nasal CPAP, I see a lot of formulas like oxygen index and a lot of other formulas. So I cannot remember them now. But you highlighted the importance of the oxygen delivery formula. Is there any other important formulas that you are practically using them inside in ICU?
So the formula, the oxygen index or oxygen delivery formula, you don't need to memorize it entirely, but you need to memorize the concept. Makes sense? So you don't need to memorize, okay, and it's equal to the cardiac output, multiply the hemoglobin, multiply the saturation, multiply 0.202, multiply the saturation or the oxygen, arterial oxygen saturation. You don't have to remember this. But what I need you to remember that there is, number one, your goal, look at the oxygen saturation to determine the oxygenation, and why we don't use the PO2 in practical way. We don't always do the arterial gas. We are fine with the saturation. Number two, what I need to remember that there is multiple factors. There's difference between hypoxemia and hypoxia, and why it's important to know about hypoxia. What's other factors that might affect your tissue oxygenation or at the tissue level. So you need to remember that hemoglobin, you need to pick on your hemoglobin, and then you need to pick on your cardiac output. Make sure that baby doesn't have failure. If you are baby septic, sometimes he's on failure. If baby has baby chin, sometimes he's on failure. So those you need to like awareness. You have high sensitive or high awareness of those parameters. You're asked about OI. I left it because I'm gonna give pulmonary hypertension, and I'm gonna speak about that one. Usually we use the OI, the oxygen index, and the oxygen index equal to your MAP, main airway pressure, multiply your FiO2, divided your PaO2. Sorry. So that's PaO2, okay? So that's your oxygen index. The oxygen index, how important to know, so that's the prediction of how bad your baby hypoxemia, how bad. That's we used only if the baby is very, very, very sick and he has arterial line and he's in the septic shock, or baby on the vasopressors. Then we know is baby on pulmonary hypertension in the severe degree that you are questioning yourself whether I need to use the nitroxide or I need to transfer the baby for the ECMO. And I will stop here because I don't want to go in detail with this one. We will discuss, inshallah, the pulmonary hypertension more, and we will explore more. But that's just to give you an answer. It's the oxygen index we use only in those parameters to determine or predict the degree of the hypoxemia. And we use number one, if your OI, just to very quick, if your OR more than 25 or 20 to 25, that means you can use the nitroxide if you have baby with severe hypoxemia. If your OI more than 45, then you need to call if you are in the tertiary center level 4, high level, then you know that you need to call for ECMO team to come and evaluate the baby at this time. So if your OI less than 40, around 40, you need to start involve them. If your OI less than 40 and arterial gas, then they're not gonna accept the baby. Just like very quick to answer your question. But I'm trying to, as I said earlier, because you joined late, I'm trying, inshallah, each time cover respiratory, add various concept of the respiratory physics and equations, so it make it sense for, I don't want to bring it one time, because what happens when we read physiology or we read respiratory physics, if you read all of them one time, you're gonna forget, you don't know what's the values. But I'm trying to each time talk about something, try to bring it so at least makes sense for people to remember, like minute ventilation, why I have to talk about the alveolar ventilation, why I have to talk about, now I bring oxygenation, why I have to talk about the PO2 versus the oxygen saturation. And then I don't want to bring OI, I'm gonna leave it, inshallah, for when the topics comes, I will talk about, inshallah.
Okay, I have another question, Dr. Ayman. Is there any window to use low dose sedation in case of baby fighting nasal CPAP?
So
the attending doctor ability on CPAP, like hypoxemia or
Yeah.
Okay.
Sedation, شوف completely paralyze the baby, that's not the topic, especially if the baby intubated.
Yeah.
Increase mortality. Just I needed to know this. So using the vancomycin or muscle relaxant, either all muscle relaxants increase mortality. Okay, their study, big study, look at the mortality using muscle relaxant, paralyze the baby on the babies, and they found that increased mortality. So we don't use it that often. But if we need it some center, they use it. Doesn't mean that is not its contraindication. Very rare occasions. There is exceptions. For the mild sedation, you can use it. Yes, you can use it. So, for example, if you have baby chronic lung disease, okay, chronic lung disease, and you don't wanna baby, you're gonna extubate him and you put him on the NIV, and you want to take a little bit stress and anxiety from the baby, you want to, and that's not meant like it's not routine, although, okay, you can use minor sedation. In fact, we adopt nationwide children hospital protocol for the chronic lung disease, the one I told you guys, the time constant, the high tidal volume, low rate, high prolonged eye time. In their protocol, once they extubate the baby, they give small dose sedation nasal to calm the baby, so at least to decrease the failure extubation rate. But is it routine? But is that the routine? No. Are we using it as a routine? Definitely no.
You mean sedation or just an opioid, like an intranasal?
The intranasal, like they use the either opioid or sedation.
Okay.
Either one, yeah. There is variation. For SAD, or you can use the there's like either opioid or these sedation. I like the what one names, forget the name, but they use both, yeah. لكن هل هو routine any baby on NIV fight with the, no, if he fight, that means something wrong. You need to figure out what's going on with my baby, why he's fighting. You don't want to take off the, sometimes he's fight because he's severe hypoxemic. He's stressed out, he has pulmonary hypertension. Yes, in case baby he has pulmonary hypertension, you might consider some sedation. So it's going to be case by case. You cannot, if my practice, I never use, at least in my practice, I never use sedation on baby on NIV. Yes, baby intubated, you might use it. Baby on IV, usually I don't use it. Just there is always risk of the giving sedation, especially opioids, and risk of the respiratory depression. I don't use it.
There is one question, Dr. Amelia.
Go ahead.
Dr.
اللي عندك question.
I already unmuted her microphone. Dr. Amelia, now you have raised your hand, so you can proceed to your question, please. I don't know if maybe by mistake. Dr. Faisal, do you want to add something?
لا أعتقد والله almost covered. أنا ما شاء الله على صراحة أنا he covered almost everything. The question صراحة اللي كان في بالي بس anyway he once he like maybe like next week or the week after, once he starts talking about pulmonary hypertension, we can ask questions.
Inshallah.
So far,
there is one.
No, I'm good.
لا في Galaxy.
Okay, I think we have one question. I will just call by the name of their phones, Galaxy A7. So you can ask.
You can unmute her.
Yes, it's already. I have already unmute her.
Her phone still appears as a mute.
Okay, now. I have a slow line today, so it's not gonna come easily.
Okay. Any other question, guys?
Could you try to unmute her, Dr. Ayman?
Yeah,
Galaxy A7.
She can unmute herself إذا كانت تقدر هي.
Okay, Ayman, خلينا نسألك. Is it true when they say like a flow rate is equal like to the weight in kilogram? Like if you have like a 3 kilo baby, you can start like 3 liter. If you have 4 kilo, you have 4 liter.
هذا براكتيك يا جماعة. They use it. I never use it, but they use it. You can use it.
Like what? How high? Like you can go? Maybe I missed this part at the earlier lecture. How far are you guys?
Manufactured تقريبا up to the 8 liter.
Yeah, that's how we use it. Like in pediatric, like in general pediatric, they use up to 8 liter.
Yes, that's the manufacturer. But for us, if you required higher flow, then you know that your baby needs CPAP. So that's kind of like the usually Vapotherm. Yes, we go to the 6 liter, but regular high flow. If I know that I went above 4 liter, then I know that my baby needs CPAP more than flow.
Let's say if you extubated the baby, and can you start like high, like maybe like 4 or 5, or you just start like 2 liter, 3 liter, or it doesn't matter?
If you extubate the baby, why you need flow?
No, let's say baby is still kind of, you know, like if you extubated the baby, but the baby still kind of have like a little bit work of breathing, maybe a little bit tachypnea.
Then are you talking about premature baby or full-term baby?
Let's say he's 32 weeker, for example.
32 weeker, usually I leave the baby on CPAP if he starts retracting. I give him CPAP. If the baby, like infant, that's not infant, like the full-term baby, then usually I start 2 liter.
Oh, okay.
And then go up if he required more. So it's like doesn't mean you can pick any number, and then you can decrease based on what you think. You get right. I mean, start 2. If he doesn't like it, then you go up 3. It's look at the retraction, look at the baby respiratory rate, look at overall your baby, and then that's what I do. At least I sit at least for 30 minutes for any changes I made. I stay and look at numbers. I look at my baby, how's baby's behave. If I can see numbers, saturation improve, retractions no more, then I know that the number I picked is right. If I see that no, my baby starts retracting, higher respiratory rate, then I know I need higher. So that's kind of like there's no magic. Dr. Galaxy 87. تفضلي.
I couldn't unmute her, Doctor. So I wrote to her that she could write her question, and we can proceed it directly to you, but she or he didn't respond. I will just want to ask one question, Dr. Ayman. It's here in Libya, there is a common practice that we don't increase the flow of nasal oxygen more than 2. This is like a common teaching and a common practice, okay? And also, as you know, there is no oxygen blender. So what I understand from your lecture that you didn't stress over this point that it is like a contraindication or it's like a mistake to go above than 2 liter per minute.
There is no, I don't think there is mistake. I think the practice in Libya, and that's, I cannot answer 100%, but I think they want to avoid the oxygen because they're using from the wall 100%.
Off the wall, I believe, yeah.
If they want, higher you go on flow, higher allowing the baby. So 100% on the 2 liter, you are talking about 30% or 25, around 25 to 30% oxygen babies deliver. So higher you go on the flow, your higher oxygenation at the nasopharyngeal level.
Is it linked to pneumothorax rate? Is
no.
there any
no,
article addressing this point?
No. Definitely no. Okay, so لأن أنت أصلاً is nothing related to that. 2 liter لأن هي الفكرة higher flow أنت بيستart regular pressure لأن السباب. أنت فهمني؟ الفكرة إن if you are dealing with the full-term baby, okay, full-term baby, you need to know why your baby on respiratory distress. You need to rule out your pneumothorax. It makes sense if you start at 2 liter and then do X-ray, and then you go up if your X-ray non-pneumothorax. It has nothing to do with that, but you need to know that higher oxygen, it's more damage than the pressure that you like. If you required higher flow in Libya, I'm talking about Libya now. If you required higher flow, because higher flow means higher oxygen, then I rather switch him to the CPAP. Make sense or no? if you
because
are
لأن ما عنديش بلندر في ليبيا، هذا اللي بيوصلها لي
yeah,
أيمن.
إيه لأن there is no blender in Libya. فبما ان no blender come from the 100% oxygen فانت higher flow higher oxygen you give to your baby. فهذا علاش ممكن هم they are try to avoid, they don't want to go up
Exactly.
لكن الفكرة التو we go up to like the I told you up to manufacture up to 8 like usually 6 we go I go higher 6 I don't remember that I went higher 6 لكن المانيفاكتشر they said up to the 8 liters so you have a room to go up لكن from 2 you cannot go to 3 pneumothorax that's definitely not the answer. It's more لأنك أنت الأكسجين that's more dangerous than the flow itself. I think in this case. Make sense?
بالنسبة مش عارف أيمن هو شكله
دكتور أيمن.
mute.
دكتور أيمن.
Yes, Dr. Ayman. Yes, it makes sense. Yeah.
إيه فهذا علاش أنا
بس لأن ما فيش بلندر في ليبيا أيمن، ما بقدرش بتحكم في الاف اي 2 بتاع يعني الكونسنتريشن بتاع الاكسجين، عرفت؟ فهذا ليش أنت ما تقدرش حسب أيمن بن عياد بيقول لك يعني ما تقدرش تمشي أكثر منها لأنك أنت تعطي أكثر أكسجين، عرفت؟ مش مثلا عندكش بلندر تتحكم قديش ما تقدر تمشي مثلا 6 لتر بس عندك 21% الكونسنتريشن فاين، عرفت؟ لكن هذه معناها اوف ذا وول، يعني انت بالعربي طالع هذا النيزل كانيولا بس من الوول، وذاك الوول 100%. طبعا مش معناها ان 100% حيمشي للمريض، لكن احنا الاوف ذا وول مش عارف ايمن انتم في الانستتيوشن بتاعكم من عياد at 1 liter ولا less than 1 you can use off the wall.
It come from the wall. What do you mean 1 liter? Then هو
like when you start the baby's off the wall like at less than 1 liter, right? Like at 36 weeks?
Wallahi, I'm not sure.
Like at what gestation, at what corrected gestational age you start the baby's or your preemie baby on off the wall high flow?
The high flow nasal cannula off the wall usually after 32 weeks لما انت try to wean him off. Okay, so let's assume that you have 32 weeks, you wean him off or extubate the baby or off CPAP. He doesn't like it. Then usually I start 2 liter nasal cannula. Okay, start with room air, 21%, 2 liter. And then let's assume that a week, 2 weeks, your baby is stable, he's doing good. Then the issue with the high flow nasal cannula, usually we don't feed the baby. That's the institution based. Okay, it's not like the nationwide. But the majority of the institution, they don't feed the baby oral feed. The baby on high flow nasal cannula. Usually they start 1 week. Okay. So I don't know what about you, Faisal, but usually a baby on high flow nasal cannula, they don't. Although I'm not saying that it's not. Some centers, I went to the AB conference, some centers, even on the CPAP, they try if the baby is stable. So there's not like the hard, like it's not like contraindication, no. But majority of centers that are trained and I look at the baby, usually on the baby on CPAP or high flow nasal cannula, they don't start baby feeding, oral feed. There is risk of aspiration.
You mean
that's the
preemie babies or full-term babies?
No, I'm talking about preemie babies. Then when you reach the 2 liter, then you wean down to 1 liter. Once you reach 1 liter, then you can offer the oral feed. And then baby stable, tolerate fine. If the baby, you know that he's gonna stay, he's just start learning the feed. He's just start learning. You're not gonna challenge him more. So usually I left the baby alone, and then until he start learning how to feed. So initially he's get small amount, he's get tired. Slowly until he become full feed. When he reached the point that he's reaching 70-80% of the feed, I know that I'm not concerned about learning the curve of the feeding itself, like through the oral feed. Then I start weaning the baby off completely and see. If the baby starts retracting or he doesn't like or desats, then I know that he needs oxygen or flow. Most likely he required oxygen than flow, so I go down to the 0.5, 100%. And then I go 0.5, give him a week. If he's stable, then 0.3, 100%, and then 0.2, and then 0.1, and then try to challenge him. If he failed, again, desats even on 0.1, 100%, then I know that's baby gonna go home on the nasal cannula.
Okay, there's one question, Dr. Ayman, regarding the use of the nasal CPAP based on the respiratory rate. The higher the respiratory rate, the more likely that you are going to use the nasal CPAP to prevent respiratory failure. This is how I understand the question.
هذا طبعا there's no هذا I don't think is the right to say based on respiratory rate. لكن انتوا كانت تذكروا انا ادويت لكم عليه الميكانيك المينت ventilation equal to the respiratory rate multiply the tidal volume. كويس؟ فانت هذه اللي هي هذه بتستند عليها. يعني شو معناتها؟ يعني you are not looking at only respiratory rate. We have baby Romer and he's tachypnic. We don't do anything. He doesn't need. He's stable. He doesn't have retraction, but he's tachypnic. He doesn't have severe retraction. He can maintain the saturation. As long as your baby maintains saturation, if he's just tachypnic, we can leave him alone. You don't need to baby.
I agree.
You don't need to place baby on any respiratory support. So the answer, just looking at one single parameters to place baby on CPAP, that's not right. But if you're telling me that your baby respiratory rate increased retraction and he start desats, then I know he needs respiratory support. I will start with non-invasive. If I'm dealing with premature baby, then I will start. I know that, let's assume that baby full term C-section. I know he has TTN. If he's retracting, granting, then I know that he needs pressure because I know that he has retained fluid in the lung. I'm gonna give him some PEEP to help the stent alveoli resolve the fluid. And then I put the baby on the CPAP. Another scenario, if I have the baby who is retracting, increased respiratory rate, premature baby, shortly 36 weeks or 35 weeks, he was fine. I said, I'm not gonna do anything. And then he starts retracting. I said, let's wait longer. And then he starts maybe transient, but he's getting worse. The nurse, she said, oh, he's getting worse now. He starts making granting or retractions. Okay, at this time, I know that that's the typical natural history for the RDS. Then I will place baby on CPAP. Another story. If you have a baby or meconium or baby all of a sudden full term start respiratory distress, respiratory rate high, and then also start retracting. If you are not sure about underlying cause, you would like to place nasal cannula until figure out what's going on. That's another option. So just link it to the respiratory rate. It's wrong statement. It's not right. I don't agree. Yeah. But you need to look at the whole picture. Make sense?
Yeah. دكتور أيمن، دكتور فيصل وباقي الزملاء، نبي نستأذنكم بس عندي شوية مشغول، وبارك الله فيكم وجزاكم الله كل خير على المعلومات القيمة والنقاش الرائع.
ما زال في أي أسئلة ولا خلاص؟
في دكتورة كميلة سملخي قلت لها تبعت لك رسالة السؤال دايركتلي لأن ما قدرتش ندير لها أنميوت.
شو اسمه؟ دكتورة كميلة، خلاص توكل على الله دكتور أيمن، جزاك الله خيرا.
شكرا جزيلا.
دكتورة كميلة maybe عندها مشكلة في الانميوت. دكتورة كميلة، أي حد عنده استفسار أو سؤال؟ فيصل أنت تشرح في الليست any question قبل ما
No, there's no questions, Ayman.
Okay, جزاكم الله خيرا. Thank you so much. So next week, what's the topic?
Well, I choose. It's fine. I have pulmonary hypertension. I'm okay with that.
أعتقد الزملاء في بعض الزملاء شو اسمه تكلموا عليه ال ABG interpretation for the blood gas. فإحنا شو اسمه أنا I'm gonna leave it for Dr. Ayman. You guys, you can send a request and we have 1 week. So I'm okay with both. But inshallah we were gonna cover on the road. يعني inshallah if we didn't cover next week, then the week after inshallah.
Maybe the blood gas you can discuss it أيمن مع يعني case scenario عرفت rather than just
which is
the whole
Dr. Galaxy A7 تفضلي وتفضلي مع عشرة لكن تقدر unmute yourself وتقدر تفضل كان عندك سؤال. Galaxy 7.
1 second أيمن 1 second. Someone asked a question. دكتور أيمن يتأخر موعد المحاضرة الساعة. I don't know what it means by ساعة يعني maybe. أيمن أنت توقيتكم الآن عندكم 5 o'clock صح أيمن صح؟
إيه إحنا 5 o'clock. إيه هو ندرتها 10 بس قلت إنه شو اسمه؟ باش تبدا كملوا التراويح والفطر والشرب قهوه وياخذ
يعني 11 بدل 10.
هذا انا ما عنديش مانع هذا، لكن اعتقد ان خلوا نسقوا مع دكتور ايمن باش تبدا على الاقل يشبح اكثر فوت انا ما عنديش مانع ان شاء الله.
يعني I guess واحد من والله مش عارف مني بس كاتب انه يا ريت انه discuss asphyxia I guess HIE
ان شاء الله.
next week.
اني دكتور اللي يسال عن الاتش اي my goal or my plan to go by system. Now we cover the respiratory. So at the end of the respiratory, inshallah, we're going to be master respiratory. All the topics is being discussed: anatomy, physiology, pathophysiology, all the disease underlying cause. وبعد ان شاء الله لو قررنا CNS حنغطوا الاتش اي ان شاء الله in details.
Maybe هي actually يعني تمشي systematic يعني respiratory بعدين تمشي cardiac بعدين
هيك الجول respiratory cardiac
عرفت يعني بعدين ممكن GI or like neuro because you know how likely you get the HIE gets I mean it's less frequent than you get the baby like NICU with hypotension for example or
لكن ان شاء الله we will cover all the questions. So the
like a cardiac shock.
We will cover all the questions. Maybe the arterial blood gas, I will discuss with Dr. Ayman to have it like a case, like sepsis, what they did for sepsis, maybe 2 providers, and then they can discuss. Maybe I will present very quick about, let me think about it. لأن في tricks I need to make sure I can explain it. محتاج ممكن have the speakers, people, they're going to present different gas and then we can look at and إن شاء الله. Let me discuss with Dr. Ayman and then we will decide إن شاء الله.
Okay.
جزاكم الله خيرا. Thank you so much. Anyone had questions that I cannot answer, especially please you can send me direct. بالنسبة للمحاضرة إن شاء الله is going to be on the YouTube. I create channels on the YouTube. أي محاضرة إن شاء الله I created إن شاء الله is going to be posted on the YouTube إن شاء الله. Just write my name and then go to the channel. We will see it إن شاء الله. جزاكم الله خيرا.
يلا. الله يبارك فيك.
السلام عليكم.